Hi everyone, thanks for joining. We're going to get started really soon. Hi everyone, thanks for joining. We're just going to wait for a few more people to join the session and then we're going to get started. Okay, thank you everyone for joining today. We're excited to be co-hosting the Healthcare Engagement Virtual Summit together with Hyro. We have some exciting speakers ready to share their expertise here with you today. Before we start, a few housekeeping announcements. Please note that today's session is being recorded. You have a Q&A box at the bottom of your screen, which you can use to send questions to our speakers. We'll be saving all those questions for the roundtable discussion at the end, where our speakers will join us all together to go through them. Let's get started and dive into healthcare engagement. So for everyone here today and for everyone who works in the healthcare industry, everyone is striving to improve healthcare outcomes. We want to keep our employees healthy, we want to keep our patients happy and retain our members. And that's why we come up with better access solutions, better services, and better enhanced benefits for our patients and members. Once we've come up with all of these new and exciting programs, the next step, of course, is to engage our audience so that the programs we build are actually utilized. And that's where patient engagement comes in. Everyone from healthcare payers, providers, and employers who are providing healthcare know that engagement is key. Members, patients, and employees who are engaged make better use of their healthcare provisions, leading to healthier lifestyles and cost savings in the long run. But engaging patients so that they're involved in their healthcare and know where to get the right care when they need it is easier said than done. We're going to be joined today by experts who are leading engagement across their various organizations and who are going to be sharing with you the steps that they've taken to engage patients and staff. They're going to be talking about engaging the right people at the right time and leveraging virtual and in-person opportunities. Our speakers today include Nick Sarantis from Baptist Health, and he's going to be sharing how he built a successful virtual urgent care program and what the patient journey looks like that resulted in a change of culture. Dorsa Barson from the Public Interest Company will be sharing key components of engaging patients and sharing a very moving story of how she used these methods to change one woman's attitude to healthcare for good. Allison Keller of Piedmont will be sharing how she used technology to improve patient engagement with the Piedmont Call Assist service and how this has impacted the patient experience across Georgia. And we're also joined by Abby Lazinski from St. Luke's Health System in Idaho, who will be sharing how she has spread the patient engagement burden across the patient journey and how they've leveraged technology to enhance this experience. We are, of course, co-hosting today's summit with Hyro. Hyro is the leading responsible AI-powered communications platform for healthcare, enabling health systems to safely automate workflows and conversations across their most valuable performances, platforms, services, and channels. This includes call centers, websites, SMS, mobile apps, and more. Hyro's clients, which include Intermountain Health, Baptist Health, and Hackensack Meridian Health, benefit from AI assistants that are fully HIPAA compliant, fast to deploy, easy to maintain, and simple to scale, generating better conversations, successful patient outcomes, and revenue-driving insights. Thank you, Hyro, for joining us today. At Tytocare, we've spent the last decade developing not only our cutting-edge home and post-market clinic solutions, but also our Tyto engagement labs, which complement our virtual care solutions. Our engagement experts have built technology strategies and journeys designed to support users in their decisions around how to get the best care that fits their family's needs, and how to ensure the best, most effective adoption and utilization of virtual care for our customers. Our work has resulted in a 50% usage rate of our virtual care solutions, significantly higher than we're seeing across the industry for other telehealth solutions. Tyto engagement labs and other methodologies that you'll hear about today from our experts all employ behavioral science to help shift patients' behavior. We'll hear about leveraging the existing patient journey to engage with them when they're already engaging with their healthcare. We'll hear about who should be leading this engagement strategy and how to get clinicians involved at the right time without adding to their already overloaded plates. There's no engagement silver bullet, but there are tactics and lessons that we can learn and implement, and I'm really excited to hear our experts share their stories today. Our first speaker is Nick Sarantis. Nick is the Systems Director of Digital Health at Baptist Healthcare System in Kentucky and Indiana. He is responsible for the system strategy, implementation, and execution of digital health solutions. This includes direct-to-consumer telehealth, async care, inpatient consults, and remote patient monitoring. Under his purview comes an interesting project that Baptist Health has been running to leverage virtual care as part of their urgent care centers. He'll be sharing with us today how they've rolled that out and how they've engaged both patients and clinicians. I'm really excited for him to join us. Thank you so much, Nick. Welcome. Handing over to you.
All right, thanks for having me. So yeah, let's go ahead and jump into the next slide. All right, so just a quick bit about Baptist. We are a 8-owned hospital system throughout Kentucky and a little bit of Southern Indiana. We had about 145,000 virtual care visits across our organization last year. Next one. So Baptist Health and Tyto. So we've been partners since 2021. We utilize both Tyto Home and Tyto Clinic. We've got nearly 1,000 Tyto homes distributed in a variety of areas. We've got 40 Tyto clinics deployed, and that number continues to grow. We've got 19 in our urgent care centers, which we'll be talking about today, soon to be 13 in some different school settings, and 11 in our primary care offices. So urgent care at Baptist Health. So just to highlight that, so we have from a virtual perspective, a 24/7 virtual urgent care department, a provider pool of around 10. We usually have about 2 or 3 that are working at a time though. That department takes care of e-visits, video visits, and our Tyto visits. It is an Epic integrated system using the in-basket workflow. We have 2 freestanding ED urgent care hybrids and a few more that are coming as well. And then we have 19 traditional urgent cares where we have Tyto clinics deployed throughout. So from an urgent care operations perspective, the challenge is, and certainly don't expect these to be unique, but predicting volume, right? I mean, certainly we can say, okay, it's flu season, we expect more, but certainly from a time and a day perspective, there could be fluctuations in volume that's hard to predict. From a provider staffing perspective, obviously finding urgent care providers is tough, right? We're looking for, probably burnt out ED physicians in a lot of ways. And so staffing continues to be a challenge. Getting staffing to the right location as well, right? We may have one location that could be at a higher volume than another location. To support the staff, we need support staff. We need front office people. We need RNs. We need nurses. We need rad techs. And all of these things, if one person calls in, can completely shut down the clinic, right? The waiting room could really pack up just with one person coming in late or not showing up at all. Certainly want to cut down overtime, after hours, right? Any dollars that we can save in healthcare this day and age is a positive. So if we can cut down on that in terms of the wait times at the end of the day, that's really helpful. Certainly we can have locations that just shut down, right? If a provider calls in sick or anything like that. Patient satisfaction, having patients wait in a room that we call the waiting room does not lead to the best patient satisfaction. So we certainly want to be aware of that. And then finally, appropriate level of care. We've got patients that come into the urgent care that are simply a cough and very simple that could be handled virtual. And of course, we've got things on the other end of the spectrum that they need to be transferred to the ED. So looking at all those challenges kind of leads us to how can we address those? So we started looking at how could we do it from a virtual perspective. And so using Tytoclinic, we placed a Tytoclinic in each physical urgent care location. We started slow in a pilot. We just put one in there in 2023 just to see if, hey, could it work? Do we have a place for it to sit? Can the technology connect? All those kind of things. Pretty quick, just from a volume perspective, probably a pilot of one isn't always the best. So we quickly expanded to 10 later that year. Um, as we started gaining some success, though, we really quickly decided to make this a part of daily operations in urgent cares, we needed to just put one in every one of our urgent care locations. We needed to make sure that our operation staff, our practice managers, when they were getting together and talking about how to run a Baptist Health urgent care, that the Tyto Clinic was part of that conversation. So doing that, and then obviously using our virtual urgent care providers to help keep those wait times down, and then ultimately support the understaffed clinic. And then for us, we looked at it as certainly zero, maybe low risk situation. A lot of, I'm sure people can appreciate IT projects take a long time to get going. And the last thing you want to do is spend all these time and resources and dollars on something that maybe not uh, successful. But for us, we just thought, let's do it. Let's try it. My team was able to really manage the project in general where we didn't have to involve a lot of other teams, which was good. So we said, let's go try it. If it wasn't working at a location or if it wasn't working at a place, we thought, hey, we'll take it out and we'll put it somewhere else. So from a patient journey perspective, as they walk in to the clinic, so the first thing we try to do is talk about and make it prevalent that there is a virtual option available in the clinic. So we've got some marketing materials at the entrance. We give patients, if they don't have a MyChart account already, we give them a quick and easy way to sign up for a MyChart account right there. We talk about how it could be potentially a lower wait time, of course. The front office staff serves as that initial triage, not making clinical decisions by any stretch, but just using really basic common sense. And we have some cheat sheets for them as well. Is this a problem that could potentially, excuse me, could potentially make sense for virtual? Is it one of those lower complexity issues? Does the patient have MyChart? If they do, fantastic. If they don't, we can get them set up really quickly. What's the wait time look like? Is it a high wait time right now? Or is it close to the end of the day or lunch where wait times could begin to really stack up? So if those questions are all yes, and we can get a patient into the Tyto Clinic room, then staff member, directs them to the Tyto Clinic, explains kind of what's going on, and then from there they go onto the kiosk, they sign into their own MyChart account, which this is I think a really important and perhaps unique step is that we're really letting the patient drive the experience. So we're not having to have a staff member or multiple staff members really sit with this patient. So this really helps us alleviate wait time. Now, once the patient signs in to the Tyto Clinic, they appear on the schedule for our virtual urgent care department. Our virtual urgent care providers, they work off, if they see a Tyto Clinic visit show up on their schedule, then they move immediately to the front of the line. We figure if a patient is waiting in a physical urgent care, that wait time should be less than somebody, sitting on their couch at home a little bit more comfortable. And so that allows us to really get that wait time low. We can do some quick testing if needed. So in terms of diagnostic testing, point of care testing in the urgent care, which is great, and then ultimately sent home. And then the rest of the visits or results, of course, are in MyChart. The provider can call if needed. So why is it working for us right now? We're seeing significant decreases in wait time for sure, and that's been the biggest thing. We're giving our patients what I call kind of the best case virtual experience. I think we've all had, as we try to grow the culture around virtual care, we've all had issues, right, where a patient maybe has a bad connection, or they had some settings turned off on their phone, or maybe it was our provider that wasn't doing things really well. And so this is really the best case virtual experience. It's connected to a high quality network that's very fast. We have support staff needed nearby if something is needed. And we also, if from a clinical perspective, if further care is needed, we have providers right there. So there's that feeling of safety. So if a patient walks in and this is their first virtual experience, we feel really confident that this is going to be a best case scenario and best experience, and it may turn them into a virtual first type of patient later on. You've got to have an urgent care staff champion, somebody that is thinking about Tyto Clinic, not all the time, but certainly a lot of the time. Where is Tyto Clinic fitting into the workflow? Thinking about, oh, well, this patient could be Tyto Clinic or this patient wouldn't. Having somebody like that has made all the difference in the world. And that's where we've seen kind of, some clinics be really successful and some maybe be so successful. Clear instructions and processes, right? Anything we can do to make the process simple requires less explanation. So things printed really large font, arrows on the floor to help with traffic, even where the Tyto clinic's located. As you can see in that picture there, we've even got little Bluetooth doorbells where if a patient is experiencing a connection issue or a question or something like that, they can just push that doorbell, which rings, and then somebody can check in on them. Changing the culture just with any virtual solution, continues to be a challenge. The biggest way to change the culture is using it, and it can be intimidating, and it can be different, right? If somebody is just going through their normal daily workflow, even if it's not going well, there's just something about being on that grind or being on that hamster wheel that it's difficult for people to want to jump off and try something new because it may not work or it may make things worse. And so really, so trying to incentivize and help people use it is the best scenario. So making it part of daily operations, like I said, putting it in every one of our urgent cares, where practice manager meetings, department meetings, operational meetings, when they talk about things, what's working, what's not, Tyto Clinic is now on the agenda as far as what's working. Using it during slow time. So there may be some times, that again, to help build the proficiency, to help build the workflow on what's working, uh, to try to take a chance, right? If a patient walks in and again, it clinically, it certainly fits. And then maybe, and again, even maybe it's a younger patient, they have my chart. It's trying to find that best case scenario of like, hey, if you want to try it, let's go try it. And that helps really build the competency. Something that my team did with the urgent care departments is we did some challenges with them. So when we installed Tyto clinics through the urgent cares, we said whoever had the highest percentage of their visits done via Tyto clinic, we would throw them a pizza party. And we did that for a couple months. And again, if nothing else, it got people talking about it. It rewarded the entire clinic for success because it really was the entire clinic in terms of really adopting that culture. So working from the front office person, the RNs, the MAs, and then ultimately the providers to help support it as well. And so that was something that was really good. From my perspective, like my team, is the digital health team. So we kind of sit in between IT and operations. But ultimately, we need operations to really support and help and communicate this. And we've really had that. We've got a good partnership with operational leaders all the way up to our COO of our medical group. And that's been really important to help change this culture. So, nuts and bolts, how's it going? So we've had over 2,800 visits from our urgent care Tyto clinics alone. The average visit duration is 9 minutes. Wait time is around 6 minutes. So you can just imagine that potential patient experience of, it's cold and flu season. They walk in, the waiting room's full. They're not feeling well. The front office says, yeah, it's going to be an hour or two. That could be the patient's first experience with Baptist Health, right? Urgent care serve as that entry point. So what could be a 2 hour wait is now a 6 minute wait, right? That really changes and potentially makes a lifelong patient for Baptist Health. Um, so we've got, our three highest clinics certainly during flu season, right? No surprise there. Our urgent care, about 66-minute average, Tyto, about 18-minute average in terms of just looking at those different patient journeys. All ages, continue to use it. And, I think that's something that we continue to see with virtual throughout, right? It's not just for those 20 to 40-year-olds. Our average age is 34, but we continue to see patients, with, infants and their parents all the way up to 80 years old throughout. And that's it for me. And I can answer any questions at the end when we do the roundtable.
Thanks so much, Nick. I actually, yeah, there we go. I was gonna say before you turn off your camera, there's a few questions that we've had that I kind of wanted to just get you to talk a little bit about now.
Sure.
Um, and I think it's really interesting how you used the pizza as an incentive. And we've seen that across some of our other customers as well, where they kind of give incentive to nurses who they're asking to use virtual care systems for the first time. They're kind of seeing that go better. I don't know if it's because people specifically want pizza or if it makes it top of mind for them, right? And I guess the questions that I had and that we had come through were around how you're communicating that successfully to both the clinicians and to get buy-in, I guess, from higher up when you're introducing the program initially. And I'd love to, if you can share a little bit about that.
Yeah, so I think, just strategically, urgent cares for us, and I'm sure many other healthcare organizations are really that potential initial entry point into a health system, right? So when you first move into a city, that may be your first experience, right? Is you don't get a doctor until you need one, and so you go to an urgent care. And so I think just from a strategic perspective, we realized really quickly that this could be um, if we provide a great patient experience, then we could have Baptist patients for life, and that's really important. So I think right away, from our higher up perspective, like that was our strategy in terms of talking with our higher ups in terms of return on investment and those kind of things. Our operational leaders, for us, it was really a good partnership. It wasn't necessarily operations coming to us and saying we have a problem, which is always nice when you're in IT. But it was kind of collaboratively of, hey, because the virtual urgent care department ultimately reports in that virtual or in that urgent care structure as well. And so we could both see that there's a resource there. They knew about Tyto because we've been talking about it. And so really it was the urgent care leaders and us working together and saying, "Hey, let's try it. We really have nothing to lose." From an investment perspective, I've tried to take, from the IT perspective, I tried to take it off the operations. I tried to make sure I had some things in my budget to help support them so they didn't feel like they had to get marketing materials printed or designed or we really tried to take some of that burden off of them. And then ultimately is really about making it top of mind, getting it with operational leaders, talking about where it fits, where it doesn't, what works, what doesn't. And then I think the biggest turning point for us was getting it into all the urgent cares. Um, there was a couple urgent cares, frankly, that we thought were a little bit lower volume. They didn't get really busy, and so we thought, oh, why put one there? But pretty quickly we realized, no, if you're operating an urgent care in Baptist Health, has a Tyto clinic in it. That's just how it is, right? When we go build another urgent care, what we're looking for now is, oh, where's the Tyto clinic going to go? And as soon as we reached that inflection point, and now it's just, again, it's just how we operate.
That's really interesting. Once it becomes standard practice, then that's what it is, no matter what. So thank you very much, Nick. I really appreciate that. We've got some more questions, which we'll go through during the roundtable. And I think something else I thought was really interesting was that so many of the points that you raised can be used for urgent care sites, but also for other types of virtual care programs, especially about that buy-in and how you rolled it out. And I think it's definitely interesting to use the physical space, and that's something that I think is a big bonus when you're looking at a virtual care space, an urgent care space, or a school, which is a different use case, but you've got that physical space that you can leverage. So, like I said, we've already had some great questions from the audience. Keep those coming in. You've got your Q&A box at the bottom of your screen, and we're going to address those as part of our roundtable session once we've heard from all the speakers. Next up, I'm excited to introduce Dorsa Barson. Dorsa is the Senior Vice President of Strategy at the Public Interest Company. She is a dedicated healthcare professional with a Master of Science in Nursing and credentials as a registered nurse and public health nurse. She has decades of experience spanning community care, value-based care, and operational leadership. And she spent her career focusing on improving patient outcomes and driving systemic healthcare improvements. In her previous role as Vice President of Clinical Programs at a network of over 2,000 independent physicians and providers, Dorsa led clinical program development, focusing on utilization management, care management, risk adjustment, and quality improvement. Dorsa, thank you very much for joining us here today.
Thank you so much for having me. I'm Dorsa. Thanks for having me. I will be talking about patient engagement, and we'll talk about a case study. Before I'm moving, I just wanted to explain, you may ask, why are you presenting about patient engagement when you work for a third-party liability company? But the first picture, actually, if you can go back, the reason I chose that picture is because healthcare is intertwined and everything's related to everything in healthcare. And of course, patient engagement is in the middle of everything that we do in healthcare. But the reason I'm here is because for many years, when I did operations, I had to cut a lot of clinical programs because of lack of budget and funding. And it was really frustrating for those of you who are in healthcare and you do these types of programs, because these programs are the first ones to be cut because there's no direct ROI, and the ROIs are always seen much later when you're taking care of patients. And I wanted to be part of a different part of healthcare that brings in more money in healthcare to be invested into these programs. So that's one of the reasons I switched. But let's talk about patient engagement. We're going to talk about defining patient engagement first, because there's different definitions depending on the setting that the patient is in. And there's also the micro definition, the macro definition of patient engagement. We'll talk about the different key components of engagement, why does it matter? How do we use it to care for patients? What are the regional and social determinants of impact on patient engagement? And what kind of using tools and technology and resources can we use for patient engagement? And then we'll talk about the case study. So first, to start, there is micro engagement and macro engagement. It's pretty obvious. Micro engagement is engaging efforts that target individual patients and focusing on their specific needs and preferences and behaviors. Our goal is to influence and improve the patient's personal healthcare experience, adherence, and outcomes. Whereas the macro engagement, its most engagement strategies aimed at improving population level health and organizational relationships with patients. So it's individual versus population health. For example, for micro, you can think about focusing the patient, encouraging them to adhere to treatment plans, providing education for specific for the patient, utilizing tools like the patient portals or mobile apps for tracking health metrics. Like an example would be a nurse providing personalized discharge instructions to a patient after they are discharged from the hospital. Whereas the macro would be addressing systemic and organizational approaches that improve engagement for the entire population of patients. So focusing on groups, communities, like public health campaigns. An example would be a health system launching a campaign to provide flu vaccinations, or policies incentivizing health plans to engage patients in preventative care. Go to the next one. And then besides the micro and macro, we need to also understand the engagement of patients in different settings. Of course, there's other healthcare settings than what you see on the screen, but these are the main ones. And what's also really important is that it's important of knowing the definition of each setting, even if you're in another setting. So if you're a specialty care, it's important to understand what's the engagement level of the patient in primary care. Again, it's not one-dimensional. It's you're caring for the patient as a whole, not just in your own setting. So some examples, and this could apply obviously in micro or macro, but in primary care settings, so clinic settings, it's important to understand the engagement, meaning that there's active partnership between patient and provider. There's shared decision-making. Trust is very important in the clinic setting. There's routine visits and follow-ups, including telemedicine. In hospital, acute care settings, it's more focused during the hospital stay, understanding their care and discharge instructions, transitional care planning, engaging with different healthcare members, like specialists. Then digital health, if there's tech-enabled interaction, remote patient monitoring, platform adaptation, there's online community engagement. Home health is more self-management support, maybe having family and caregiver involvement, focusing on activity of daily livings. Specialty care, again, would be managing multiple treatments, regular monitoring, and then behavioral health would be coping skill developments, long-term engagement strategies, and regular assessment and feedbacks. Again, the key here is that understanding how different settings work and how engagement works in those settings. Next, please. And then we're going to talk about the components of engagement. So there are different components of engagement. There is patient activation, health literacy, self-management capabilities, regional and social determinants of health, and technology versus human touch balance. We're going to focus more on the micro engagement examples. Of course, they can be applied to macro as well, but we're talking about individual patients, so we're going to focus on micro engagements. Next one. So for patient activation, what's important with patient activation and to understand is, as a case manager or somebody who's caring for patients, and you obviously have a huge load of patients, and you have to understand which patient can I make the biggest impact on. It may not be the most expensive or the sickest patient. For example, you can have a patient who is type 2 diabetes, and they're still on oral medications and they're not on dialysis yet. Or you can have a patient who's already on dialysis. To me, as a case manager, it's a lot more important for me to focus on the patient who is not on dialysis yet. They're earlier on their type 2 diabetes. I can probably do more preventative care measurements and care for that patient to try to delay their progression of disease. So it's not about just, okay, just focus on the sickest and the most expensive. It's really finding patients that you can actually make an impact on. And to make that impact, you have to understand patient activation. How are the patients willing to activate in their own care? So we use a tool that's called the Patient Activation Measure, or the PAM tool for short, which measures the patient's knowledge, skills, and confidence in managing their own healthcare. It's a 13-questionnaire assessment. There's 4 levels, and the scoring ranges from 0 to 100. Lower scores it's scored to 1, 2, 3, or 4. Lower scores are 1, higher scores are 4. And you have to and it comes in multiple languages. And you administer it repeatedly to measure progress. If somebody can go from a level 1 to a level 2, 2 to a 3, 3 to a 4. And what's important here, you have to understand the different levels and where the patient is in their own activation to be able to help them achieve the care that they need and the education that they need. For example, for level 1, you would be focusing on building basic knowledge. You just want to have small goals and just to try to get them to do, for example, if they need to take their medications correctly, just take that medication correctly. Or for level 2 would be you're educating them more about their conditions. They're a little bit more engaged. You help them with problem-solving support. You do regular checkings. Level 3, they would be more advanced care planning, goal refinement, and obviously supporting them to stress management techniques. And then level 4 would be long-term goal settings and maintaining support for them. So how you use the PAM tool, you do the initial assessment and you match the intervention based on the score. And then you progress tracking and then when to reassess them. And then you tailor the interventions and the best practices based on their their score, and then you measure the outcomes afterwards. The other important thing to think about is health literacy. That's the ability to obtain, process, and understand basic health information to make appropriate health decisions. There are key elements, which are understanding medical terms, reading and comprehending instructions, interpreting test results, following medication directions, understanding risk factors, navigating healthcare systems, their level of education, do they have reliable access to health information, language, cultural preferences. And if you want to look at it on the macro level, whenever you're creating educational material, it's really important to have them to be at a 5th grade level for masses. And then obviously it needs to be short, relevant, and targeted. Next. And then we're talking about self-management and shared decision-making. Self-management is the skills and abilities needed to manage day-to-day health needs, whereas the shared decision-making is collaboration between your patient and the provider to make health decisions. It's really important that you follow these 3 steps, that you understand the knowledge, skills, ability, and willingness of patients to manage their own and family members' health, the culture of the health organization that prioritizes and supports patient engagement, and the active collaboration between the patient and provider to manage their health outcomes. So for self-management, it's important that the patient is adherent to medications, they do symptom monitoring, lifestyle modifications, problem solving, managing multiple conditions, using health tools and devices. And then for shared decision making, there's open communication with providers, setting mutual goals, weighing risks and benefits, regular feedbacks, and having treatment plan adherence. And then another important thing to consider are regional and social determinants of health. I worked in Northern California in 3 different counties that were 10 miles away from each other, and each county was completely different from the other. And so there was urban versus rural differences. There are available resources that had by region. There are transportation access issues, and there's healthcare deserts where there's only one provider for hundreds of thousands of patients. And it even mattered when I visited the patients or the providers working with how I dressed, depending on where I was going in the county, and to build the trust with the patients and the providers. And then there's also the social determinants of health, education level, income and employment, housing stability, food security, and social support. And then obviously the county level factors, what are the local health services, what are the community resources available, what are some of the cultural characteristics in the county, and then if there are any health disparities. And then finally, the use of technology. The biggest important thing about using technology is finding the right mix between tech and human touch. Knowing your population is really important. What's the line of business you're working with? Is it Medicare, older population, commercial lines, Medicaid? How old are your patients? How empowered are the patients? And then what type of digital engagement tools works for the patients? What are you using that you're seeing that it's working? Is it patient portals, mobile health apps, remote patient monitoring, telehealth? And do you have the ability to evolve? What kind of communication strategies are you using with your patients based on their population? Are you setting SMART goals? Do they understand what the SMART goals are? How are the documentations? Are they clear action plans? And then what's really important is this piece that also Nick pointed out in his presentation about engaging with traditional methods. It's really important that your technology that's being used is endorsed by PCP and specialists. Like Nick said, they had a champion staff member. That was really the key to their success in integrating it into the physician's workflow so it works, and then knowing patient's information. When you're calling the patient, for example, if you're calling and saying, I'm calling you from this patient remote monitoring, if you don't know patient information, they're not going to trust you and think it's a scam. And then implementing strategies Is the patient technology ready? What are the cultural preferences? Are there any access issues? What are the communication strategies? And making it simple. Making it simple, I have always a good example of this. I don't know if any of you know Hobby Lame, which is the guy who went famous by making silent videos on YouTube, on TikTok. Basically, he shows like really complicated videos, and then he does it really simply, like eating a banana or something, and then he'll just, point and say, duh, like this is how you do it. He doesn't even say anything, he just points with his hands. Really, that's like an example of me, that for me, for simplicity, our brains as humans, we like simple, and simple works. So if we make the technology too complicated, patients might use it once or twice, but it's not something that would be used on an ongoing basis. Okay, so now the case study. So this is a real case study, and my case management team actually worked on this. We brought it to round. We talked about this patient. So we had a 55-year-old Hispanic female. She had type 2 diabetes, hypertension, and depression. She lived in Napa, which is a rural community in Northern California. She was a migrant worker, limited English proficiency. She had limited transportation access. She used public transportation. And if you've ever been to Napa, it's not very easy to get around with public transportation. There's not a lot of buses. Husband, also a migrant worker, but has recently was deported. Adult daughter lived about 2 hours away north. She lived in a communal housing. She was referred to case management from the primary care provider's office at FQHC, Federally Qualified Health Center, for uncontrolled diabetes, hospitalized for 2 days for hyperglycemia. She had multiple ER visits in the past 6 months, and she was a no-show at her endocrinology office. So think about what we could have done with this patient. So we did an initial reviewed the chart to understand the patient history, patterns, reading the doctor's information to understand before we contact the patient. She was assigned to a bilingual case manager because we knew that she spoke Spanish and she didn't speak English very well. The bilingual case manager made initial contact with telephonically, and was determined that there's many challenges and there needed to be a face-to-face visit. There was lack of trust given that her husband was deported. She agreed to meet face-to-face, but not at her home, but somewhere outdoors in public, which we made that happen. And she had told us that she missed her appointments because of transportation issues, and she was not taking her medications correctly because she didn't know how to get her insulin and afford it. So the face-to-face visit happened. The case manager did the PAM tool administration in Spanish. She had a PAM score of 2, meaning she was willing to engage, and wanted to engage in her healthcare, but just didn't have the right tools. Some education material was given to her about her diabetes. The case manager already knew she had transportation issues, so she took the material with her and helped her fill it out, the paperwork to apply for the services, transportation services that the county offered. Additional challenges that were identified was she had limited health literacy. She had food insecurity affecting her diet management. She was unable to afford glucose testing supplies. She had lack of understanding of her medications. She had depression, which was affecting her self-management skills. And then she had limited technology access. She had a basic smartphone, but very limited data. So she only used it for calls with her family members. So this is the care plan the case manager came up with. She was referred to care coordination services that we offered to set up patient with transportation, food bank, medication assistant program enrollment, and additional Spanish language diabetes education. She was referred to a diabetes program that we had in the county as part of a disease management health plan program. She was referred back to her PCP for depression management. We created a simple blood sugar logging system and medication adherence tracking for her. And then she had weekly phone calls for 3 months, once a week by a care coordinator, and if necessary, referral to a nurse if she needed to to talk about her medical issues. And her outcomes after 6 months, her PAM score increased to 3, so she was more willing to engage in her health. Her A1C decreased from 9 to 7.8. Her blood pressure was within target range, consistent medication adherence. She actually completed a visit to an endocrinologist, which our case manager helped in setting that up. And she had no ER visits in the past 6 months. And she continued to follow up with her PCP via telehealth for controlling depression and diabetes management. And that's all, folks.
Thank you so much, Dorsa. That I really enjoyed the outline and then the deep dive that you gave us. And I don't know if you remember, but when we did our prep call and you told me this story, I was, it's so touching to, obviously it's a difficult case to have to manage in the first place, but to be able to see the impact that we are able to have on patients' lives by taking these steps, by building programs that really are engaging them and meeting them where they are. That's really why engagement is so important. And I think it's a great look at what we can do with the tools that we have. So thank you very much. And I'm excited to get into some questions in the roundtable as well. Before we invite our next speaker to join us, I want to share an upcoming event with you. I mentioned schools briefly before, and we are hosting another virtual summit on February 5th about school virtual care programs. We've already got some exciting speakers lined up from MUSC, Avel eCare, East Tennessee Children's Hospital, and more. And it's going to be a really fascinating look at school health programs from experts who are running them. So if you are interested in joining, a poll has just popped up on your screens. Let us know and we can share a link to that event for you. We can even sign you up automatically to save you some time. While you're filling that in, I'm just going to remind you again that you can leave some questions in the Q&A box at the bottom of your screen for our speakers, and we'll add them to our roundtable discussion, which is going to happen in probably about an hour from now. Thank you very much. We're going to close that poll out now, and I'm excited to introduce our next speaker, Allison Keller. Allison is the Vice President of the Patient Connection Center at Piedmont, which is one of the largest healthcare organizations in Georgia. Allison works on several different initiatives to improve the patient experience while maintaining effectiveness and efficiency at Piedmont. Her team handles scheduling for 18 hospitals, as well as all pre-service functions such as insurance verification, patient liability estimates, and pre-registration. And today, Allison is going to dive into one of those initiatives with us and share how she worked to increase patient engagement. Thank you so much for joining us today, Allison.
Thank you for having me, Joanna. Good morning, everyone. And thank you for joining. I'm going to talk a little bit about a project that we've been working on for about the past 6 months or so, share our experience so far. So just a little bit of an overview. Joanna gave kind of a highlight, but for those of you who aren't familiar with Piedmont Healthcare, we are a nonprofit health system based in Georgia. And at this point, we are covering most of the state of Georgia, and around 80% of Georgians live within an hour of a Piedmont hospital. We now have 25 hospitals, as well as multiple urgent care sites, quick care locations that are located primarily within Walgreens, and then many Piedmont clinic partners. So we have cover all kinds of specialties, including heart and liver and kidney transplants. And we have over 47,000 employees, which makes us the largest Georgia-based employer of Georgians. So just a little bit of an overview to give you an idea of what we're supporting here at Piedmont and within the Patient Connection Center at Piedmont. So just a little background. So what we have is what we're calling it is our Piedmont virtual assistant or call assistant. And so The Patient Connection Center, which I'm responsible for, is handling around 10,000 inbound calls a day across multiple service centers and service lines. So we are connecting with patients, providers, and insurers. Our primary contact is with patients, and we are mostly taking inbound calls from them to handle, get them scheduled for services at both our primary care, our cardiology locations, as well as for hospital outpatient services. We also handle making pre-registration and payment arrangements, and then taking those calls. And if there are questions or concerns for the providers, we are sending in basket messages to our providers or telephone encounters to our providers so that they can respond to those patients and their concerns. We also support our providers and receive those orders from them to make sure that their patients are getting scheduled, but we also handle surgery scheduling and work with the provider offices to get those cases scheduled, et cetera. And then, of course, working with insurers to do the insurance verification, authorization, and so forth. So the issue we were really focused on is continuing to optimize our patient experience as well as the efficiency within the connection center. So really looking at how we can continue to provide a high level of service to our patients while also keeping our cost within check and kind of bending that cost curve that we all hear so much about. So we were looking at different ways to do that, and looking at putting a call assistant in place using a virtual assistant. So the solution that we came up with, again, was utilizing Hyro to work to help us with implementing that voice assistant. But looking at the top here, prior to implementing a voice assistant, we had your basic call tree or call menu, right, where you would call in, you had to listen to options and select the option that maybe fit your needs the best. And so you can see an example there on the screen of what that call menu looked like. And so once you chose that option, you would then be entered into a queue and wait for someone to answer your call. Our hold times, our target is 80% of calls are answered within 30 seconds. And that really varies based on volumes and time of year. But we end up running somewhere probably around 70%, specifically on our provider, or our primary care call queue. So the opportunities we had, again, was we have many call entry points and call trees that maybe frustrated callers. We really didn't have any self-service options, except maybe if you just wanted to listen and hear maybe directions to the clinic or so forth. And then we were continuing to onboard practices, and our call volume was continuing to increase as we continued to grow. And we just really couldn't necessarily keep up with the staffing to keep our call levels where we wanted. So again, how could we really deliver a better experience for our patients? And so working with Hyro, we were able to develop a voice assistant. So now when at the bottom there, when the patient calls in, they are greeted with a voice assistant. That voice assistant sounds very natural. It doesn't sound robotic. And it really basically just starts out after it greets the caller by asking how the caller can be assisted. And then the caller can just speak in their natural language and say what they are calling about. As long as that is one of the items we have identified and developed routing for, then the call can go through the self-service. And you can see some examples here of where we engaged or implemented self-service. So we allow them to reset their MyChart passwords through that, or get a link sent to them that where they can reset that password. They can confirm their appointment, cancel, reschedule their appointment, hear clinic hours, And then just really a big component of it is also just helping make sure they get routed. If they do need to speak with someone, that they get routed to the correct person that can best handle their needs. And so if they cannot be supported through self-service, then the call will still go to a queue and go to a person to answer that question. Or they can always ask for an agent. And if they ask for an agent, after that second time, they will be routed to an agent. So the approach that we took, we really started working on this, as you can see, back in January of 24, so a year ago, with discovery, worked on our build. It was quite detailed, mostly just really working on the routing and where the calls should go, because for the pilot areas that we selected, which again were our primary care locations, our quick care locations, and our MyChart support calls, a portion of those calls still were routing to the practices. And so when we talk about multiple practices that were being supported, we had to determine for all those options exactly where in the practice each of those would route. And so that took a little bit of time to work through and determine that. So you can see I've talked a little bit already about our use cases, but we really focused primarily in the beginning on an existing appointment. So we didn't want to, since this was a pilot and kind of our first learning of using a voice assistant, we didn't necessarily want to jump head first and start with allowing people to actually schedule appointments, but we did want to allow them to cancel or reschedule appointments. And then it worked very well, of course, on our MyChart support with password resets and things like that. And then for our quick care locations, those do not have anyone at a desk. And so all of those calls are coming to our contact center. And those calls we have been able to have some success with. So you can see out of all of the calls that we receive per month into our locations, which is nearly 1 million calls, we piloted with around 130,000 calls a month and engaged in a 120-day evaluation period where we looked at it, refined what we were doing, and continued to make improvements. So as we worked through the call assistant with our outcomes, transparently in the beginning, our metrics were negatively impacted with the assistant. I don't think that's necessarily surprising because it was new to everyone. It was new to the callers. They had to get used to now having an assistant greet them and not having those menu options that they were used to. So that took some time. And of course, out of the gate, there were things that we didn't necessarily think of or know to expect that we identified along the way, and then rapidly worked to improve. So we were having multiple calls throughout the week to continue to identify those things and work through those, and we're able to make improvements. So here on this slide, as you can see in the middle, we had multiple different things that we have done to address those impacts. So one of the first things was there was background noise that we were receiving or hearing. So when someone, especially in the car, for instance, there might be some background noise, or there might be someone else in the car with them. And I think one of the things no one thought of is that often people are having maybe sub-conversations at the same time. And so it was picking up some of those sub-conversations, and or even that echo or feedback that you hear sometimes in the car, it was picking up, and it was causing calls to not necessarily route correctly. And so we worked together. Really, Hyro worked on that to reduce the noise cancellation, increase the noise cancellation, so reduce that ambient noise that was causing those problems. We also worked on rescheduling parameters. In the beginning with rescheduling, we were really limiting that and not allowing, for instance, people to reschedule appointments that were going to happen in less than 24 hours. And those were still routing to agents. And so that was really negatively impacting our ability to allow the patient to self-service, because there are certainly reasons why people need to cancel or reschedule due to something, that maybe came up or something within 24 hours. Same thing on the cancellation. And so we are continually looking at and revising those parameters to see really what is the right fit. Along with the parameters as far as when they could cancel, we added some additional capture of information to capture the reason for the cancellation, which is then coming over into our EMR. And so the person who sees that cancellation can really see why the patient canceled in their own words, and not just a random cancellation reason. Part of what we rolled out was a conversation summary for our agents. So once that call transfers over to the Patient Connection Center, we wanted to make sure that the agents weren't basically asking the caller to repeat everything they had already said to a voice assistant. I know personally that frustrates me whenever I interact with a automated assistant where I'm having to repeat everything I've already told that assistant. And so we created a conversation summary that would come over into our CRM, so that we would know exactly what had already transpired between the caller and that assistant, and therefore could improve our interaction with those patients and help get them what they needed or where they needed to be in a quicker manner. A big piece of what we worked on, I'm sorry, can you go back? A big piece of what we worked on was the salient terms. So the salient terms is really what improved the routing and making sure. So really continuing to refine again what terms it is listing for and how those calls are routing to get the patients to the right location. And so that really improved that routing and reduced the patient's frustration. And then you can see we added a couple of other things, including really putting the large language model feature in place for our quick care calls, which you'll see improved the experience and our outcomes. And this is a continual work in progress. We are continuing to work to identify any additional opportunities and continue to improve the process. And we are looking in the near future, we will begin working on adding additional skills and things that patients can do through self-service, as well as adding additional call types to what the voice assistant is helping with. So going on to the next slide, what I want to talk about just is a little bit of what the results were from that continuous work that we've been doing. And so you can see over on the left here where we implemented that large language model that I talked about with Quick Care, which really the large language model is really tapping in and ability to really understand more of what the caller is trying to say, and not just looking for specific terms, but tapping into that large language model to really understand what they're saying and directing their calls better. So you can see here we were able to improve our deflection rate. So for the case of this, the deflection rate means that those are the percent of calls that we were able to actually deflect and not have to connect with an agent. And then from there, the purple and the orange shows where we were actually able to resolve the completely resolve the caller's need without handing off to an agent at all. And so you can see how that improved as we continued to refine our processes and improve that experience and the routing of those calls. So we're continuing to monitor this and see the improvement as we continue to make those updates. And then over on the right, we have this similarly with the appointment cancellation. You can see that when we removed some of those parameters and the prohibitions we had in place, that we're not allowing people to cancel within certain timeframes. How in December, when we did that, that really allowed a great improvement in our resolution rates, and not having to hand those off to an agent. And so, again, I think the primary lesson here, or the takeaway, is that it's not necessarily something you can just put in place and forget about. It's something that takes continuous monitoring and refining to continue to improve that customer experience and help them to get where they need to be and help us deliver the experience that they really are looking for, and allow them to do self-service when they want to, but also allow them to get to a live person or an agent when they want to.
Thank you so much, Allison. That was really fascinating. And I think what you mentioned at the end there especially was a really good lesson for us all to learn across any engagement tools that we use is we can't just roll something out and leave it there. And I think what was really interesting that you spoke about was that kind of learning process that you had on the go, and how you were ready for that and how you were prepared to make sure that this wasn't a one and done. This was a constant improvement. And I know that's something that you're still working on. And I'm excited to hopefully maybe have you back next year and kind of see how this has continued to improve. I think that could be really interesting. So thank you very, very much for sharing that with us today.
Thank you.
Thank you. Before we head to the next speaker, I want to share a piece of exciting content with you. Hyro, our co-host today, surveyed over 1,500 US patients to learn more about their preferences, expectations, and concerns when interacting with their healthcare providers. They've put all of that together in their Voice of the Patient report, which is designed to give you insights into what your patients are thinking. And we're excited to be able to share that with you today. There's a poll now live on the screen. And if you're interested in receiving that after the summit, just pop yes, please in there. And we'll get that over to you once we're off the line today. Whilst you're filling that in, I'm just going to remind you again that after our next speaker, we're going to be joined again by all of our experts in a roundtable discussion. And if you do have any questions, pop them in the Q&A box. We're going to close that poll out now. And I am excited to introduce our final speaker, who is no stranger to our virtual summits. Abby Lazinski is the Director of Outpatient Telehealth at St. Luke's Health System in Idaho. She has over 16 years of experience in healthcare, serving in many different roles, including Director, Program Manager, and she's also a licensed practical nurse. In her current role at St. Luke's, she has built a new on-demand virtual care service line, which allows anyone within the states of Idaho or Oregon to have access to medical care via a virtual visit. Abby, thank you so much for joining us here today.
Thank you so much for having me. I'm so excited to talk to everyone about patient engagement. As Joe mentioned, I have been in many different roles throughout healthcare for actually 18 years here in January. And the patient engagement term, it means different things throughout those different roles. And so I've learned a lot, and I'm hoping to share those learnings with you today. As a nurse, you're thinking about how do we get patients to engage in their care, so they're taking their medications appropriately, so they're coming to their appointments, they're going to their physical therapy, right? And then as you move into IT, your focus is how can we build our workflows so that patients stay engaged. so that they're looking at their MyChart. They know they can message their provider. They know they can make appointments, right? And then as you move into operations, it's more about how do we make sure patients are engaged so they know how to access our services. And if you had asked me 5 years ago, where does patient engagement start? I probably would have given you a different answer than I would give you today. And I think there's a lot of components to patient engagement. We talk a lot about tools, and those things are certainly important, and we do have to have those things in check. But I actually think it starts somewhere different. And I believe that patient engagement starts with your culture. And I've had just the amazing honor of being able to create a culture on our on-demand team. So on-demand really means that, and that is patients join with a provider in the moment, real time. We do not put any sort of barriers around who can join a visit. It's just you get straight to a provider, and we've built a culture around that. To have that type of team, you really have to be focused on the patient and their engagement and their experience, and really thinking about them as a consumer. And so that's what we built for the past 3 years, is an avenue that is the quickest to get to a provider. We don't triage them. We just get them straight to a provider, let the provider triage if they can treat them virtually. That it requires a lot of innovation and open-mindedness about how are we going to make sure that when we don't have all the answers, we're still able to provide a really good experience in the moment. We have hired a team that goes above and beyond for every patient. And I think when you work in healthcare, if you ask somebody, can you tell me about a time you went above and beyond for a patient? They're going to tell you, well, I go above and beyond every day. But really thinking that way and not putting the burden on the patient for the convenience of the system, I think that's something that healthcare can always get better at. And I think, and I will talk a little bit more about that as we move through our other slides, just about how you really do that and how it's different than what you might be thinking of today. It's always worth our time to see a patient. So sometimes providers can have this, they've been taught to think, well, if I can't bill for the visit, then it's a waste of my time. And that's a culture that we've been able to think about differently, in that if the patient is in front of you and you're giving them any sort of guidance, even if you're not charging for that, it's still worth your time because we're giving patients guidance. We are an extension of every team in our system. So even though we are a virtual team, we are able to extend primary care and obstetrics and occupational health and multiple specialties within this one virtual team, because we really do think of ourselves as an extension of every team. That really creates an integrated experience that I'll talk about a little bit later. And then thinking about patients as consumers. So when you think about any business, they have to think about anybody who accesses their services as a consumer. So they really have to make sure that experience is the best that it can be, or they will not come to access their services. And so in healthcare, we've kind of been able to get away with this way of thinking that, well, people will always access our services because people get sick, they need healthcare, and they always will. And so sometimes we tend to put more burden on the patient to be able to accomplish our system goals, and I'll talk about some examples of that. On the virtual team, we don't have that luxury. We really do have to take on more of that consumer burden. If they schedule wrong, we're going to change the visit type for them, not ask them to reschedule. If they didn't fill out their questionnaire ahead of time, we're going to help them do that real time. And if they don't know how to schedule an appointment, we're not going to make them call 15 different numbers. They have a direct access point to be able to do that. So that's a couple of the examples of thinking about them as a consumer and making sure that that experience has the least amount of burden on them, even if that means putting more of that burden on the staff to be able to support that. And then finally, our providers are local. They live and work in the community that our patients live and work. We do hire bilingual providers and medical assistants as well. So that same type of feel that, you are a part of my community, you can speak my language, and that all of those things feel like it is built around that patient. And so they are more willing to engage in their care and participate in that shared decision making when they feel like this is built for them. And when we have patients respond to our surveys, that's what they say. And it was easy. It was, I feel like this provider went above and beyond for me. And I mean, I could tell you story after story of some of the things our providers do, and you wouldn't believe that the amount of time that they spend coordinating care for patients in the moment. These are not dedicated appointments. These are queue-based appointments, and they are able to coordinate care in the moment for patients when nobody else would have had the time to do it. They didn't meet the criteria to have an appointment with anybody else, or they would have spent a lot more money going to an urgent care or emergency department trying to get that care, which often is not coordinated for you in those settings either. And so this culture has quite literally changed lives because we're able to take those extra few minutes and staff so that our providers have those extra few minutes to go above and beyond and really start that conversation of engagement and care. So I want to talk a little bit about that burden that I discussed throughout that culture conversation. So when you think about the burden of healthcare access, I mean, patients are coming to us in healthcare already with burdens, right? Thinking about their health, things that they're worried about, things that they're worried about for their family. How are they going to get to their visit? How are they going to get childcare to be able to attend their visit? I mean, they're coming to us with a burden. And if you could think about that burden as a box that they're carrying, and from the minute that they schedule their appointment to the minute that they leave their appointment or they access whatever their after visit plan is, such as physical therapy or picking up a prescription or whatever they might do after that visit, if you think about that entire experience, how many more things are we adding to that box? How many more things are we asking for them to take on so that we can have a little bit easier process? So I'll give you some examples. How many questions are we asking them in a decision tree for them to be able to schedule their own appointment in MyChart or your patient portal that you may have? How many times are we asking them the same questions they just filled out on a clipboard or a questionnaire iPad when they get into the exam room? They just answered the questions, but we're going to ask them those questions again. When we do those types of things, we are adding to their burden, and therefore they feel less engaged after the visit. They're less likely to go to their physical therapy appointment or their follow-up appointment with that provider if it was a burden the first time that they were accessing the care. So when they are accessing care, they have to feel like that burden is more shared. And that's why I titled this discussion the way I titled it, because we have learned in the virtual care area where you really have to get it right the first time or they're not going to use virtual again. Virtual is something that isn't native to everyone. A lot of people use it for the first time, even today when we've had virtual care for several years. And you have to get it right. And so we have learned and staffed and coached our team to be able to take on that burden. So like I said, we don't have any decision trees. They get straight to a provider. They can immediately schedule that appointment. That requires a lot of effort and system support to be able to have that type of setup. And I 100% realize that, but it's worth the effort because we're able to catch those patients that would have never been able to access care otherwise. We are a rural state here in Idaho, and so some of those transportation issues or accessing an urgent care, that they aren't an option. And so we have to have the ability to be really flexible and make those services at the forefront of everyone's mind and make those experiences really delightful so that they will come back and they will not delay their care because they live in a rural location. So I've talked a lot about the patient burden and how we take some of our own burden and put that on the patient. But there's also a burden that we carry as being healthcare providers and support staff. And that burden is something that you hear all the time, and that is efficiency. So the reason why we make patients answer a decision tree that has 50 questions in it is because we're trying to be more efficient and make sure that they're scheduled to the right visit type, right? And the reason why we have them fill out the paperwork is so we can file it in the chart, but the provider doesn't have the time to read all of that before they go into the room. And so they're asking some of those same questions because they want to be efficient. And so I guess my cautionary tale is be careful with that word, because sometimes we can try so hard to be efficient, which is helpful for the patient because we stay on time and they appreciate that. But there has to be a balance in how much we're willing to put on the patient to be an efficient system. And sometimes efficiency can be more focused on the system and what we want versus what the patient wants and needs. And so when you are thinking about building your workflows for patient engagement, when you're thinking about building scheduling in your patient portal, enhancing it, think about that balance of, okay, what are we going to ask the patient to do? And what are we willing to take on ourselves so that the patient doesn't have to do it? What are we willing to negotiate here? Because there's always some things we have to ask of the patient first. We do have to ask them to verify their medications and their allergies, right? We have to ask them to provide what medications they're taking. There's no way getting around that. They have to tell us what they're allergic to. If we have never seen them before, we wouldn't know that unless they tell us. And so there's some things they absolutely have to do, but there are things that they don't always have to do. And it's something that we can do for them. And so the more that you can take that burden, the more they're going to be engaged in their care long term, because they feel that. They feel that simple difference of, I'm going to go ahead and change this for you, or this department can't accept your referral, but we're going to go ahead and send it to the other department that can, rather than asking the patient to then call a different number. So thinking about those simple shifts in how you engage with the patient and what you ask them to do, it makes a huge difference in their care journey. And they will come back to your services when they feel that difference. So, moving on to kind of keeping that burden in the back of our minds, just when you have that mindset, it really drives your workflows. And I'll be honest with you, building this culture and building this way of thinking, it's hard work, but it's 100% worth it. And when your team really begins to think this way, their job just becomes so much more meaningful, and they're willing to go above and beyond because of that. And so I'll give you some examples of some of the shifts that we've done on our team, just so you can kind of think about that balance of burden as you're building your workflows. So we have our patients join virtually, like I had mentioned, and they get added to a queue. They are given a wait time when they are added to the queue. It's visible when they schedule. But sometimes that wait time isn't accurate for multiple different reasons that are hard coded into my chart and that we can't control. And so we recognize that. And instead of just, accepting that it's not always accurate, we actually have our staff immediately call the patient after they schedule their visit. So they're added to the queue, we see them, we call them. Hi, we go over the things that they have mentioned in their chart, just in case they forgot to add an allergy, and we tell them what their expected wait time is. What's really interesting about this is, a lot of what we do is we test different things and we try different things and we see what works and we remove what doesn't work. And we've tried it without calling them and telling them their wait time right away, and people abandon a lot more quickly, even if the wait time is only 10 minutes. But when you call them and tell them what their expected wait time is, it does a couple of things. It lets them know that they're in the right place, that people see them, and they didn't make a mistake. And number two, it sets their expectations. So even if it is our peak hour and it's the day after Christmas, because the day after holiday is always the busiest, and our wait time happens to be an hour at that given moment, they will wait the hour because a couple of things, they're waiting at home, but also because you set the expectation. And a lot of times people abandon those types of waiting rooms because they don't know if when there's a 10-minute wait, 15-minute wait, they don't know. Like, maybe I did it wrong. Maybe they can't see me Maybe they're closed today, right? All of these things go through their mind, which also adds to that burden that I mentioned. And so we just want to immediately remove that burden of worry and let them know we see you, and this is when you will see the provider, and I'm going to help you get through any of the things that you need right now so that the provider has all of your chart updated, everything's ready for you, and we can focus on the care that you need. I mentioned that we accept the burden for the patient. So sometimes patients schedule for themselves instead of their child. That happens quite often, especially if you're familiar with my chart. It's really easy to go in under your own name and forget to change to your child's name to make that appointment. We don't ask them to go back out and schedule under their child. We just schedule the visit for them. If they schedule a few minutes before we close, instead of waiting for them to do this check-in process, and then now it's after 8 and we're closed, we just call them and get them checked in right away and get them to that provider before we close. If they just think about anything that a patient could do incorrectly, we're going to just fix it for them and not ask them to change things because they scheduled something inappropriately. So really just continuing to take that burden on for the patient because it helps them and it makes a better experience. And like I said, they feel that difference. We have multiple notification options. So when a patient is ready to be seen by the provider, we can send a notification via text, via email. We can send a direct link to the video visit. So just the biggest thing with engagement from a tool perspective is giving options. So in my chart, we have multiple touch points, not just one, where they can access our virtual care or our other scheduling options. So that no matter where they are in their process within the system, that they can actually easily get to what they're looking for. We also have integrated offerings. So within our virtual team, I've mentioned that we're able to offer multiple different services, not just urgent care, not just primary care, but it also means that no matter what number you call in our system, if you meet criteria for virtual, you're offered a virtual visit first. And that really creates such an integration between our in-person teams and our virtual teams so that our in-person teams can really focus on patients that need to be seen in person. They can have more access for new patients, which I don't know if other states are struggling with this, but in Idaho, new patient access is a significant struggle. There just aren't enough primary care physicians for our population. And so if we burden their schedule with those quick, easy visits, then they can't see the new patients that need to get established. And so we're able to be an integration point for the entire system to take care of those immediate needs. And then that opens up access across our system for other things. We have clear communication after the visit. So patients can message our providers immediately after, and they have a clear plan in my chart that's visible to them. They can see the notes. And a couple of things about this communication after a visit. We also have a population focus where when a provider that is in a specialty sees a patient that doesn't have a primary care provider, we're actually reaching out to that patient and getting them into a virtual visit to establish care. And so we're really closing that entire loop. We all know that a patient can't just see a cardiologist as their primary care physician. They do need a primary care physician as well, but because they're seeing their cardiologist, they often don't ever get established for the other things that they need to get established for. And so we're proactively reaching out to those patients and getting them scheduled and making them really feel like we see them and we see their journey and we want to help make that better. And so it's not just about that immediate visit, but it's about looking across the system and seeing how we can make that interaction with our system better by that doing that outreach. So moving on to some of the other things we've done, like I said, tools and technology are really important. And so I wanted to share a little bit about some of the tools we are using in case you are interested in more of that technical side. So on the next slide, we have mention of the patient portal. So for us, it's my chart. For you, it might be something else. And really thinking about that patient portal with that burden balance that I mentioned. So the more that you can make that easy, the less questions you have to ask before a patient can schedule their appointment. The more things you can put on their homepage to help direct them easily to the services that are the most wanted. Obviously that patient portal is really important. And sometimes that means, and Epic might have to close their ears if they're listening, but sometimes that means you might have to customize that patient portal for that experience to be better. If something in that patient portal just doesn't make sense, even if that is the out of box verbiage, and you know that it doesn't make sense, and you know that patients have complained or they are frequently making errors because it's not clear, just customize the language. It'll be so much easier for the patient and your system in the long run, and it's worth that extra, again, burden of that maintenance from an IT perspective to be able to do that if it means that the patient has a better experience and things are done more correctly in the system. We have scheduling options. So like I said, that virtual first option, if a patient talks to nurse triage, they're offered virtual for certain criteria. So really just whatever the touch point is, whether it is on our website, or it is a phone call, or it's a phone call not just to our call center, but to a specific building, whatever it is, that experience needs to be the same and the options need to be the same and they need to be clear. So that we're speaking the same message, and patients then can learn what the options are. And when they're in that moment, they don't think that their only option to access care at 5 p.m. on a Tuesday is the emergency department. If patients think that is their only option, we have done this wrong. They need to know by calling, by looking at our website, by remembering the last time they talked to us, what their options are. And so we build all of our tools around that way of thinking. So our website has a guest option. Our website has different touch points that mention the different ways to access care, regardless of what page you're on. You'll see different types of notifications on how to access that care. And in-person options as well. So when patients are seen in person by a specialist and they don't have a primary care provider, they are going to get a phone call from the on-demand team to be able to establish care. If they are seen in person in an urgent care and wait times are high, they are going to be offered a virtual visit right there from the urgent care to be seen quicker. And so just more options, which I will be honest with you, has taken years to develop, because sometimes we tend to think, well, that's my patient, and I want to get the RVUs for that patient. And again, we're taking that burden, we're putting it back on the patient. Let's take that burden on a little bit, so you don't get the RVU personally, urgent care provider, but that the system is getting the RVU and the system is taking care of that patient. And then when they get established with that primary care provider, then they are taking on that care moving forward. So it's really a different way of thinking. And, we've done this in healthcare for many years. And so it's a little bit of a habit we have to break. But if we break it, again, the patient will feel more engaged and they're more likely to be a part of their care journey than to just be watching it. And then that after visit education that I mentioned, educating them on what they need to do after their visit, educating them on what their choices are to access care next time, and educating them on how to use our tools. This is how you use MyChart. Do you have an account? These are the benefits of having an account. And so we've seen a significant increase in our activation rate because we have done that extra work after the visit. So that is, I believe, everything I have for you today. Hopefully that helps you think a little bit about how to develop your workflows to engage the patient, and when it makes sense to put that burden on the patient because you have to, and when it makes sense to take that burden for them so that they can be engaged in the future.
Thank you so much, Abby. That was really, really insightful. And I think, you spoke a lot about that balance between, who takes that burden. And I'm really excited to get into that a little bit more in the roundtable, because obviously there's pros and cons to that, to which way you kind of go with that. Before we do dive into our roundtable, for those of you who are interested, we're opening applications for Tytocare evaluation kits. This will include a Tytocare kit that gets sent to you so that you can see how it works and how it could potentially integrate into your virtual care programs. You'll find the link to that in the chat box now, so please head over there and fill in the link if you're interested. I'm now really excited to move on to our roundtable discussion. So I want to invite all the speakers to join us to answer some of your questions. If everyone can turn your cameras back on again, welcome. And we're also joined by C. Yahav, who is Tytocare's Director of Tyto Engagement Labs. So welcome, and thank you all for your wonderful presentations. It's been really, really insightful having you and hearing your different projects and different programs. I want to start with a question that I think probably everyone will have an answer to. Nick, we touched on this slightly at the beginning, but I want to talk a little bit about buy-in. So, you've all mentioned it to kind of different degrees. But when you're launching a new service or when you're doing something that requires a change in habit for the staff, I'd love to get and this is a question that we get a lot at Tyto. We're launching a new virtual care program. How do we get the staff to get involved in this? So I'd love to get some of your takes on what you've done internally. And if it's okay, I want to kind of throw this question, Abby, to you first. And I'd love to have everyone just kind of chime in, or I'll start calling you.
Sorry, you were frozen a little bit there. I don't know that I caught just a buy-in from the system.
Yeah, buy-in from the system, from all the different stakeholders, and how you've gone about that, and tips.
Yeah. So I do work in a department called Consumer Access and Experience. So everything we do is thinking about that patient as a consumer, but it also means everything we do is change. And people do not like change. And that is from every level of any system. Change is tough. And it takes some time to prove why you need to make that change. So I would say data is really, really important. The more that you can show the data behind why we need to make this change, with IT, you got to have the data to show them why we need to customize this piece of Epic when Epic says we shouldn't customize it. And once you get leadership support on why we need to think about these things differently, even when it's uncomfortable, then you're able to drive with the rest of the system. So you kind of start at that top level leadership first, and then everything else will follow. But I'm not going to say that it's not hard and that you don't have to fight for it, because you do. And the more that you can have that data to back up what you're fighting for, it makes a big difference.
Thanks, Abby. Maybe Allison, Nick, I kind of already picked your brain a little bit on this at the beginning. But maybe Allison, Dorsa, C, does anyone want to chime in?
I can chime in.
Go ahead, Allison.
Okay. Really, I think it's really engaging the staff in some of the decision making and the process, and engaging certainly the leaders along the way to help with designing whatever you're implementing, etc. But we've also done a lot of education and engagement with them, with the staff leading up to our go lives, and as well as surveys and so forth, to make sure even once we go live what their feedback is. So not only looking at that things from the perspective again of the customer, but also from the side of the staff, as well as what they are hearing from the customer, and then taking that feedback and trying to use it also in our continuous improvement. So I think the change management is always the hardest part of anything you try to implement. That's certainly what I found, and it's along the same lines of what I talked about earlier, is you can't just put something in place and think, oh, that's going to work great and fix everything. It's still that continuous cycle of improvement along the way.
Thanks, Allison.
Yeah, I think I was going to say a combination that it's really important to engage the staff as well when you're making the changes because they're the ones who are doing the day-to-day and they might have some ideas of how to implement it to other staff. So having their input is really important. And then, like Abby said, showing the data that this is going to make your work more efficient and it's going to, in the long run, it's going to help you. I think that helps a lot. So I think everything everybody else said, but all together, I guess.
Yeah, and I would just say one more thing is not be afraid to try, even though you don't have all the answers. Is try something and see if it improves it, see if it doesn't, and then that's your data too. But sometimes we want to have all the answers before we try, and then we end up never trying because we never find all the answers before we can. And so that's been a huge part of the change is we're going to try, but yes, we might fail fast, but then we've learned from that, and we can make something even better.
I do want to add, Abby, also in line of what you said about trying new things. What we have learned is that before we're trying different like techniques or a way to change the habits or like workflows. We try to do also like kind of analysis of like what's the incentives, what the motivation, because we have found that obviously it makes sense to all of us that people are very much different in what motivate them. So when we come up with different tactics that can apply to different like personas, we found it like more effective or, and kind of like making them going through this change.
Thank you so much, everyone. I want to, does anyone else want to jump in? Because I've got a whole list here, things I want to get into. I want to address simplification a little bit. So we know healthcare is complex and the way that patients are accessing their healthcare can be very difficult for them. How have you simplified messages in a way that can resonate with patients and lead to action whilst overcoming barriers like health literacy and information overload? And if it's okay, Dorsa, I wanna go to you first, because I think this really ties in with what you were talking about.
Yeah, I think the important thing is, like I said, is understanding where your patient's coming from and the individual micro level, what their cultural preferences, language, and also just understanding what they need. Like I've had patients where just writing up a list of their medications and putting it on their kitchen table or on the fridge help them to remember to take their medication. It was as simple as that. Like just write it big, put it in the kitchen because that's where they go every morning to drink their water and they would remember to take their pills instead of putting it in medication boxes, So I think it's just like setting up the goal to that patient. And of course, it's very difficult in healthcare settings to just do micro level because it's very individual's care and it's expensive. So you do have to have some kind of a macro level of understanding of engagement and being able to create something that everybody could use. But like I said, I always use this simplicity, just make it simple, to the point, not too long. If you're sending letters to patients, it needs to be 1 page. And you need to have in the first line what you're asking for, because people only read like 2 lines and then they don't read the rest, so it's just simplicity and to the point. And if you're asking too many questions, ask the first question, the most important questions first, so you keep the people engaged and get the answers, because by the end, maybe if they're filling out 50 questions, by the end they're just saying yes, 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 because they just want to finish. So kind of like what Allison was saying, like taking the burden off and just less is more. So I usually just did that kind of a technique. And also like obviously the teach back method and understanding, like when you're explaining something to somebody, ask them if they understand it, don't just assume.
Thanks, Dorsa. You've literally described me filling in questionnaires. So see, I wanna go to next.
I would like to add to what you said, Dorsa, and I would like to kind of connect to less is more. So the way that we like to think about it, how do we map the existing user journey, the existing engagement, that anyway, we all as patients or as consumers are gonna engage, with a health system or with a product. And instead of like adding another layer of communication, so how do we take what we used to engage with anyway? For an example, in Tytocare, so, and as consumers, we're all very much used to get, delivery emails or confirmation email upon ordering a device. So instead of adding another layer of communication, we try to embed the messages and the values that we want to convey in those communications. For an example, when someone is about to receive their Tyto home kit, so they're getting an email that the package is about to arrive, and we embed the instructions of what they need to do, how to activate the kit in this email. And this itself, by the way, increased the activation rate by 30%. Right? Because it's something that we all as consumer are very much looking forward to engage with. We open the email and it set the expectation, what do we need to do? Another guidelines that we try to follow is thinking in bite size. So instead of like giving 2 pages of what do they need to do to activate, for an example, or what do they need to do to set up a service, we try to guide the patient, the users, as they interact or engage with the solution itself, like with the app, and not telling them everything in advance, but let the app to guide them what do they need to do and what are the steps that they need to take. And we found that this is more like effective from an engagement perspective.
Thanks, V. Does anyone else want to jump in on this one?
I think it's what everyone's already said. I mean, you just have to keep it simple and straightforward and not try to accomplish too much in one thing. And I agree with you, Joanna, on the questionnaires, right? Like sometimes you're like, okay, I'm just ready to be done with these questionnaires.
Just the one thing that I'll add is that something that really worked with us is because we were in managed care. So, you're doing quality care, risk adjustment, utilization management, case management. So there's a lot of touch points with the patient. And we try to have the one person, whoever is touching the patient or talking to the patient, to try to cover everything. So if a case manager is talking to the patient and they see that the patient needs to go in to get their A1C done, that they wouldn't just say, oh, sorry, that's quality, I'm not going to deal with it. They would say, hey, you have an open gap, or not to the patient, they wouldn't say, but they would understand that the patient has an open gap, and they would say, hey, you really need to go get your A1C done, or you really need to go to your primary care provider and get an annual wellness visit done, so they could to close the risk adjustment gap. So it's like, just take advantage of speaking to the patient and try to cover everything instead of having 6 different phone calls to the patient and 3 of them unanswered. So I think it's really important to just make it, again, less is more. Just one contact with the patient and try to go to ask whatever you have within that health setting.
Thanks, Dorsa. And I think, Nick, that ties in a little bit with how you're managing it on the urgent care side, because obviously you've got that kind of front. It's a bit different because they're in person, so it's actually almost in a way easier to communicate with them. But you've got that kind of front desk, which is like the triage of that solution. How are you? Do you do any kind of remote communications, or is it all on site?
Yeah, it'd be all on site there. Remote communications would come after the fact, like the after visit summary and, any follow-up messages, from the provider to the patient. But on site, it would be that individual essentially.
Okay. Cool. We have some questions here specifically about urgent care settings. So I think these definitely Nick, Abby, and then of course anyone else who wants to jump in as well. I don't want to spend too much time getting into the Tyto clinic, kind of drilling down into the product, because I want to make sure that we're adding value and not kind of doing an accidental sales pitch. But there was a question here specifically about kind of the chief complaints that you're able to address with that. And then how I think it would be interesting to hear kind of what you learned, and then how you were able to kind of shift, and how you were able to kind of learn on as you were rolling these out, and what you were able to learn, and how you shifted care potentially from virtual to in person once you saw that something wasn't working or was working better.
Yeah, I mean, I think not to make it all Tyto, but what Tyto allows us to do, is I think enhance a traditional virtual visit, right? It gives us some clinical diagnostic information that we wouldn't have otherwise. Now, the beauty of having a virtual urgent care department is these providers, they practice every single day on how to treat things virtually, and so how to treat it empirically. That is, I think, a really big point, right? Most people practicing now did not go to med school learning how to do a virtual appointment, both from a clinical and probably customer service perspective. But these providers every day, that's what they're doing and living, and so they can certainly treat the vast majority of things empirically, which is great. Things that we've learned, just kind of working with clinical leaders are GI issues. At first that was something we were, trying to treat, but the urgent cares and working with the clinical leaders felt like there's a lot of times that they actually will refer that out to the ED, depending. So that's something we just kind of eliminated from kind of the virtual offering. So if it's a GI issue, we eliminated that. And in terms of things that are, working well, it's really, again, everything that you would think that works well from a just traditional virtual perspective. It continues, it continues in that regard in the Tyto clinic space. It just, I feel like, ear infection is the best example, right? Again, the ability to actually see it. Again, you can get there empirically for sure, right? Asking the right questions and those kind of things. And but again, just seeing it does certainly change the game there. So it's really, that partnership operations, partnership clinical leaders, and when something, and again, a lot of it is living in it and learning it. And so, like, again, the GI issue is probably the best example I can come up with of something we kind of removed, from that.
That will make sense. Thanks, Nick. I've got a couple more questions. And then I think let's see how many we can get through in the next 10 minutes or so. I want to talk a little bit about scaling. And Dorsa, this is something that, as you were talking about your micro, I was kind of thinking, okay, but how do we translate that to the macro? And I think, Allison, your system is kind of actually focusing on the macro initially, but I'd love to kind of understand how you're balancing those kind of individual patient needs with the need to scale and with the need to scale efficiently. Dorsa, you mentioned just now, like writing it down and putting it on the fridge. Great. We can't, it's not always possible to do that for every single patient. It's not always possible to help make sure every single patient has a pill box. So I'd kind of love to get your take on that a little bit, how you're scaling, whether it's up or down or personalizing.
Yeah, I mean, I think that's where technology comes in, right? And I think that's where there's this fear of, oh, AI and machine learning is going to replace my physicians or my caretakers or whatever. But the reality of it is, no, it's actually helping to become more efficient. So providers, doctors, nurses can work to the best of their license and do the work that they need to do by not having to do a lot of the paperwork or follow-ups that could be done maybe with machine learning or AI. So I think that's the huge thing of technology coming in and also staffing it correctly. So for example, for us, when we were managing patients, like I mentioned in my case study, we had care coordinators who are not licensed clinicians, but they were trained to do all the other things for patients that doesn't require a nurse to do it. And the nurse would only step in when it was clinical needs, right? So again, working to the highest of your license, and then also using technology properly in the and kind of the use of technology with the human touch and getting it integrated in your system. So again, like Abby said, using certain modules in Epic that would make your life a lot easier because it would take 1 click instead of 10, which would save you 10 minutes, So so I think the use of technology is how you can expand do the best work you can with, and then also the choosing, like I said, one of the reasons we do PAM and all of that is choosing the right patients to work with, because sometimes you can get into a spiral trying to help somebody who is maybe a PAM 1 and who's very sick and already like on dialysis, and there's not much you can do. So you need to understand like which patients you need to focus on, because a lot of times people say, oh, we need to focus on the most expensive patients and try to bring the cost down. That's not really realistic, because it's too late. And by the time you get the data, some of those patients are dead, unfortunately, because it's claims data that you're getting, you're not getting real-time information. So you really need to understand like what kind of data is our friend, but too much data is not our friend. The right data is our friend. So using the right data to know which patients to go after, to which programs to create, and also the use of technology to work with those patients.
Thanks, Dorsa. Does anyone else wanna jump in? I feel like this touches on something that all of you spoke about. If anyone has anything to add.
I mean, I think it also goes back to getting buy-in from the system to be able to have the staff to support scaling specifically us calling every single patient to give them the wait time. That might sound like, how is that scalable? We are able to do that really effectively. And, it does require more medical assistance than we started with, but it's worth it. And we've seen double the volume in our virtual care environment from 2023 to 2024. So when a lot of people are seeing that decrease, we're seeing an increase, and we do believe it's the experience and that extra staffing that has made the difference. So it's getting buy-in for the investment sometimes to be able to have the staff to support some of those workflows that you need to scale.
Thanks very much, Abby. I want to ask one more question because you all touched on this, and that is about staff champions. We've spoken about pizza. We've spoken about different kind of angles that we can take, but everyone, I think, to some extent has said, find a champion, whether it's in leadership, whether it's somebody on the ground. And I think that this is also something that we've heard from our customers that has really helped them, but has also been a struggle to identify the right people. And so I'd love to get your take on how you're finding the right people, how you're leveraging them, and how you're helping them or amplifying them through the system to give them the most power as a champion that you can. And Nick, because you mentioned pizza and now I'm hungry, I'm gonna start with you.
Yeah, food and bribery obviously always work. So yeah, I think it's I think my team does a really good job of engaging, partners, and really bringing them, part of the of the future, right? Like getting a partner that's like, hey, like this is where we're going, not just healthcare, but just society, like being excited to be a part of technology, to be excited to be a part of trying something new. And I think it's to the right person. That's really scary to some people, and that's really exciting to a lot of people, right? To be an innovator, to be that type of individual. And so we try to find those kind of people and bring them in board, and maybe up their digital literacy, give them some additional training, send them some other articles that maybe isn't their daily job, but just like, hey, just saw this article, like thought you may find it interesting. So I think just getting those partners, and again making them a part of the journey, and making them a part of the excitement probably has been my team as doing that with the operational leaders' biggest success.
Thanks, Nick.
Yeah, I think, physicians are really important in healthcare. People will listen to a physician sometimes more than others. So having physicians really support the cause makes a big difference. I think if you can prove the reduction in the cost of care for the patient and for the system, that speaks volumes to senior leadership. And so that's one way that you can get the support and champions. And then just shared values, right? So I know I mentioned in my presentation, like people can connect to making a difference every day in the community that they live in. And so the more that you can share those values and keep coming back to them, it brings everybody together to support what you're trying to accomplish.
Thank you,
Another
Abby.
thing that worked for our organization was we found that physicians are very competitive, especially certain specialties. So actually showing report cards and showing them like where they are compared to their peers made people a lot more engaged and want to help and want to be the champion because, oh, well, I'm the best, so I can teach others, so of course incentives too, but it was just like simple as showing report cards and like how everyone is compared to their peers, because physicians are very competitive and especially in certain specialties like ortho, and you all know. I don't need to tell you, but yeah.
And the last thing I'll just add is we really made it part of our leadership development program, right? It is people that step up and participate in part of the projects and so forth that we're doing. One, at the staff level, those are, the people that you potentially are looking at for your future leadership positions. And then if the leaders that are jumping in, and helping, or that we're identifying to be part of the champions, are typically those that we are potentially looking at, for our succession planning, or, helping them develop to get to their next level of their career. So I think that's the other way to really engage people and help them understand how being part of these projects and things can really be a win for them as well.
Yeah, and then you've got the double win of keeping those people on board. They're already your champions, and then you're not kind of losing them, and that it's a double win. Great. Thank you all so much. I want to thank all of our speakers, and I also want to thank everyone who joined us today. Thank you for your time and for the excellent information and projects that you shared with us. We're really excited to hopefully have you back, especially Allison. I'm keeping that in the diary for next year. I want to have you back and hear more about the program. Have a good day, everyone. Thank you so much.
Thank you.
Thank you. Bye-bye.